Good evening, everyone. We are going to be discussing a very interesting and a very important topic today. But before we begin with our discussion, I would just like to briefly introduce the Empower T1D movement. It is founded by a dynamic group of young clinicians who are all united by a shared commitment to strengthening and supporting type 1 diabetes community. The mission of Empower T1D is to, as the name suggests, empower people living with type 1 diabetes. Through active engagement and collaboration, we aim to build awareness and education around type 1 diabetes by breaking barriers, dispelling myths, and making quality care accessible to all. At Empower T1D, we believe that when science meets community participation, we can create a future where everyone living with type 1 diabetes can lead their best quality life. So, with that, let's move to our today's discussion. We have seen that over the last years, there has been a surge of obesity in India, and it has not spared our type 1 patients either. So, today, why is obesity important in people with type 1 diabetes? Why is it important to manage obesity in people with type 1 diabetes? And what steps we can take to do the same is what is going to be discussed by two very eminent speakers. Our first speaker is Dr. Pavitra Nagaraj. Do we have the introduction slides? So Dr. Pavitra Nagaraj is a senior consultant. She's a pediatric and adolescent endocrinologist at Narayana Health City in Bangalore. She is the secretary of Pediatric Endocrinology Association of Karnataka. She is also the EBM for IIP Bangalore. She has been the past treasurer and joint secretary for Pediatric Endocrinology Association of Karnataka. She is author of a Kannada magazine called Sutra, which is related to science and health. And she's been a faculty at many state and national level conferences. So Dr. Pavitra is going to give us a brief overview of obesity in type 1 diabetes. And our second speaker for today is Dr. Akansha Patria. Can we have the introduction slide? Yes. Dr. Akansha is working as a consultant adult and pediatric endocrinologist at Ananda Endocrine and Retina Clinic in Surat. She is a visiting endocrinologist in most multi-speciality hospitals of Surat, Navsari, Viara, and Bardoli. She is one of the author for the book on diabetes and women. She has been invited as a guest lecturer at many national conferences. She has many publications in newsletters and national journals. Her keen areas of interest are in managing diabetes in the young, gestational diabetes, thyroid disorders in pregnancy, pubertal disorders, pituitary disorders, and postmenopausal osteoporosis. So Dr. Akansha will be talking a little bit about the use of drugs in management of obesity. Over to you, Dr. Pavitra. Please take over.
Thank you, Anushree, for that nice introduction. Can I just share my screen? Is my screen now visible?
Yes.
Yeah.
Yes.
So we've been talking about type 1, the management, the hypoglycemic episodes, the sick days. This is kind of a very interesting topic. We're going to talk about obesity in type 1, which we've been talking in type 2 and other scenarios. But it's very interesting that we have been seeing obesity, and Empower has taken this topic to discuss with everyone. So as we talk about type 1, we've always seen a child with type 1 like this. That is, the child comes with loss of weight, polyuria, polydipsia. But what are we seeing nowadays? This is what we are seeing even in type 1. It's not only in type 2, but we are seeing obesity in type 1 as well. But what is causing this obesity in type 1 diabetes? The main cause is the hyperinsulinemia. That is because of the newer insulin analogs, the pumps, the insulin carbohydrate calculation, which every child has been doing. They're intensively taking insulin therapy. They eat, they take insulin. They eat, they take insulin. So that is what is causing hyperinsulinemia. As all of you know, insulin is not a catabolic, it's an anabolic hormone. So that does lead to weight gain. So this is the most commonest reason why we are seeing hyperinsulinemia and obesity in type 1. The other is the eating habits. We are easily accessible to all the junk which is there in the market, thanks to all the apps which is there, like the Swiggy, the Zomato. Just a button and the children themselves starts booking online. So the eating habits are the ones which is causing obesity. Lack of physical activity leading to sedentary lifestyle, especially in children who are adolescents, who are giving competitive exams. They're hardly going out, hardly having any physical activities. They're always onto their books, studies, tuitions, and many more other reasons why there is a lack of physical activity. In the olden days, when we were kids, we used to go out and play. And now, because of the traffic, one, the kids are not going out. Two is because of the parents who are scared to send girls outside to play. So there are multiple reasons why they're not going out, and that can be another cause for obesity in type 1. Apprehensive about the hypoglycemic episode, especially children who are on CGMs or children who are unable to tell their symptoms of hypoglycemia. They are going into a mode of defensive eating. They're scared that the child is going to go to hypoglycemia, and they start eating just to maintain the blood glucose level. So that is another reason why we see obesity. Stress, sleep deprivation because of the studies, because of having those numbers on the CGMS or having those numbers on the HbA1c puts them under a lot of pressure and stress, which can again lead to overeating, can lead to obesity. Of course, the adolescence during the pubertal period, where we have other hormones which are rapidly increasing during the early morning, like the progesterone, which can lead to insulin resistance and thus causing increased intake of insulin, leading to obesity indirectly. So overall, what we think is eating habits, sedentary lifestyle, hyperinsulinemia because of taking of more insulin, apprehensive of hypoglycemic episodes, and during the adolescent period. So these are the main reasons why we are seeing obesity in type 1. So what are the effects, or what does it affect in type 1 children? The main reason why we are worried about obesity in type 1, like type 2 or any other child, is the insulin resistance. So, what we mean by insulin resistance is the insulin stops acting at the periphery. It starts accumulating and causing symptoms like acanthosis, that is pigmentation of the neck. It can cause irregular cycles in children because of PCOS, many other reasons which we are worried about. The other is hypertension. Because of the increased weight, we do see high blood pressure in children, which can be an effect of obesity. Dyslipidemia is another reason why we should be worried about obesity in type 1. Kindly look into their LDL levels, which may be deranged. Cardiovascular risk, like we talk about cardiovascular problems in obesity in adults in type 2 diabetes, we are also worried at the same time, even in other children with type 1 diabetes. The other reasons why we are more worried about obesity is the non-alcoholic fatty liver disease, which is again due to the obesity in type 1. Not to forget our microvascular complications like the nephropathies, the peripheral sensations, which has to be looked into. So overall, not only type 1 comes with loss of weight, they also come with weight gain, and all these parameters has to be checked yearly, or if you feel that the child is increasing in weight, you might have to do it every quarterly or annually, all these investigations. So giving you a picture of the causes and the effects of obesity in type 1, My colleague will be talking, Akanksha will be talking about the treatment and the management and how can you get rid of obesity in type 1 children.
Thank you, Dr. Pavitra. You very beautifully summarized the problem of obesity in type 1 diabetes. And yes, we are seeing a large number of people with type 1 diabetes who are developing obesity and something that we very commonly call nowadays as double diabetes. So, over to Dr. Akansha to tell us how to tackle the problem.
Very good evening to one and all, and it's a privilege that Empower team has invited me today, and I'll be very delightful to have an interactive session on this topic because, as it's been very rightly pointed out, it's a very interesting thing because many a times when patients come to us, children with type 1 diabetes, adolescents with type 1 diabetes come to us and we are seeing they're pounding in weight and we want to give them something that can help them in reducing their weight along with the medical nutrition therapy, the lifestyle changes that Pavitra madam beautifully highlighted that the need of an hour is that. But along with that, there are a few things which our dear adolescent children require as an help or adults type 1 diabetics who start pounding a lot of weight. So I'll be trying to discuss this more and more and understand the problem that most of our children are facing. Is my screen visible?
Yes.
All right. Thank you. So I think I'll be just brisking through a few things that I would also like to highlight with the risk factors and some contributing factors to this adding fuel to the fire in a patient with type 1 diabetes because already they are on some molecule which is an anabolic molecule and with as madam rightly pointed out with pumps being in use we have a lot of children they do not see the amount of carbohydrate intake they are taking and they just feel it as a leisure that I can just take a bolus from my insulin pump and I can take that food and it is not going to make my sugars rise. But it is very important that since a type 1 diabetic child or a patient is diagnosed, they should be made understand the importance of the calorie intake they are taking and the amount of calorie expenditure that they are doing. This makes a very important point because they always understand that sugar per se, the increments in the sugar that they see are the only problems. And that is why after 10 years jumping into type 1 diabetes, they develop more and more insulin resistance because now, at simple units, which were giving them good glycemic control, good sugar control, now double insulin requirements are required because of the insulin resistance that they develop. So, it is very, very important that the amount of insulin requirement drastically increases as we are unable to control the amount of insulin usage in their initial phases of type 1 diabetes. I think Madam beautifully highlighted regarding the complications. Why is it mattering so much? Type 1 diabetic, all the more they always think we are taking ma'am insulin. Now you want us to bother about the weight also? See, my dear friends, it is very important that we are here, we have to cater some needs, some, prevent some complications that can happen early in your life, which can be easily prevented without, pounding on the extra weight and with proper food management. It is, I would just imply a very important thing. It's not always the carb counting and the insulin that you're taking. It is the amount of carbs that you're taking in your food should be first talked with the nutritionist rather than just taking a biscuit and trying to sublime the effect of that spike of sugar that it is giving you. Very importantly is the coronary events, the heart problems that the type 1 diabetics can face, the heart failure problems, the dyslipidemia was discussed, and we have lot of type 1 diabetics who come to us after 10 years and they were not seeing me before and they have developed diabetic retinopathy and nephropathy because they have now developed a lot of insulin resistance. And the problem is that we used to have earlier type 2 diabetic patients only having obesity and now you can clearly see that the type of diabetics are not remaining behind. They're also up to the tune of 40 to 60%. So we have got now type 1 diabetics who are diagnosed maybe for the first time also, but having central obesity, and they do not have type 2 diabetes. So now let's come with the options that we have. The most important thing, whether it is type 2 diabetes or type 1 diabetes, I am very much
Dr. Akash,
consciously. Hanji.
your slides are not moving.
So it is moving here. So I'm on which slide now presently?
Only it's the first slide that's on. Yeah,
Oh,
now we can see this. Yeah, thank you. Sorry to interrupt.
no. So now are you able to see the options that we have? That slide?
Yes, yes.
All right. Thank you, Anushri. So, what are the options that we have? The foremost option, whether you're a type 1 diabetic or you're a type 2 diabetic, or we are treating you, we very well acknowledge the importance of lifestyle changes. If you're not calculating the amount of carb intake you're taking, the saturated fats you're taking, this is not the deal done. Secondly, how much you're expending, the physical activity. All type 1 diabetics feel, ma'am, should we really exercise? So that question is any day, not only for type 1 diabetes, it's also for type 2 diabetes. It's for everybody. And typically, because of insulin being an anabolic hormone, you should definitely be into some kind of sports activity. And you very well know the amount of calculations which can be definitely made with the physical activity. And do not fear about hypoglycemia, because it can be easily prevented with few nuances that your clinician can help you with. Third would be the behavior of the parents and the children and the family, for the most important thing. The amount of food that we are trying to inculcate in their habits and in their pattern right away from the age of 4 is going to imprint on them. And then making changes becomes a very important task and very difficult task for that matter.
Is the screen frozen? Is Dr. Akansha frozen?
Yes, ma'am.
Yes, I think there is a network issue.
Right. Okay. I'll just message her. Yeah, okay. She'll probably join back. Hello? Okay. Yeah. We are waiting for you. Right. So Dr. Akansha will be joining us. There's been some internet technical issue. In the meanwhile, if there are any questions, maybe we can take 1 or 2 questions while she joins.
No questions yet, ma'am.
Okay, fine. So Dr. Pavitra, what do you think is, as what you've seen, is probably one of the biggest barriers when you try to achieve weight loss in children with type 1 diabetes?
So, am I audible?
Yes.
Yeah. So actually, the mentality of parents are anyway he's taking insulin that will, probably cover his blood sugars, and they're really not bothered about the weight gain the child is having, and they are kind of rigid when we talk about the weight management, especially in type 1. So I have few kids who are, very adamant to go on sports, or it's especially the central obesity which is increasing in kids. So they're like, they come to me with the HbA1c levels, say, okay, the sugars are normal, but when we look at the weight, it's much beyond the 97th centile on the BMI. So we are kind of facing this uh, a problem with the parents where they're not ready to accept when we talk about the weight gain. And also, not everybody initially would have the comorbidities like the dyslipidemia or hypertension. Maybe a few years down the line, they might come with comorbidities. So we will have to check on their, as I mentioned, the blood parameters regularly, so that we keep telling the parents that weight gain is not good in any child for that matter, irrespective of type 1 or type 2.
Yes, that is true. They are very, very resistant to physical activity
Yes.
nowadays.
Yes.
And most of the times, what I've seen is that the parents stop the child. because they are
True.
worried about hypoglycemia.
True.
So there is an excessive fear of hypoglycemia, which I've seen in a lot of kids and families. And uh, with carb counting, they do carb counting and they take the amount of insulin they require, but they don't try to balance their food.
True.
So I think the protein intake probably goes for a toss,
Um,
and uh, and I think
more
overall
yeah.
we are all much less physically active than even us compared considering the situation and continuous construction ongoing in India everywhere.
True.
So
So those are the constraints we have when we talk about the physical activity where because of the traffic, because of the pollution, even I'm down with cold now, so I wouldn't want to go out whenever we are sick and down with something. So there are many other factors which are putting them into less physical activity, into sedentary lifestyle. So at least we can tell them to get into some physical activity which they can do at home, like they can opt for yoga, which will relax their body.
yes,
So that's one thing. They don't have to go out for a walk. They can opt that at home and they can start doing even that. And most importantly, as you said, the carb counting, even though we have less physical activity, they should watch out on their carbs. Yeah,
thank
Akash.
you, thank you. So, Dr. Akansha has joined. She can continue.
Uh,
Yeah.
yeah, I'm extremely sorry. Very rare, but it's not in my hands. Slides are moving, right? Yeah.
Yeah.
All right. Extremely sorry. So now we'll be talking about the medication aspects. So for type 1 diabetics, we have to be very vigilant on the amount of benefit that we can give versus the amount of risk that we can offer to type 1 diabetics. So based on that, we'll be talking about the few options, anti-diabetics that are available with us. And we are also using them in a few patients. And I'll be trying to give you one of the highlights of the same. So the most common and the most age old molecule is the metformin molecule. The GLP, the GIP, these are the incretin, twin incretin molecules that we have been now using rampantly. The SGLT2 inhibitors. So these are the four most commonly used molecules in our clinical scenario. And what do these molecules do? So let's come to the first molecule, the metformin. So metformin basically is not currently approved, but why would we use and where would we use? We'll be talking about that. What does basically metformin do? It is basically inhibiting the production of glucose from the liver, and it also helps the peripheral organs and the muscles, the liver, to utilize the sugar, and in that way, it helps in very beautifully tackle the problem of insulin resistance. So typically, our type 1 diabetic girls, if I can give you an example, who develop PCOS because of insulin resistance, metformin plays a beautiful role helping them not only cater to their insulin resistance problem, help them in weight reduction, and also help them for their anovulatory cycles to a great extent. We also have some clinical evidence for that. And with the 19 RCTs, including 1540 patients, it had shown that the amount of insulin reduction is not too rampant, but the insulin resistance reduces. But also, the HbA1c reduction can be seen. Important would be this is not to be used as an molecule for reducing the insulin dose of our patients per se, but we very well understand that insulin resistance itself is going to pound our patients to have more insulin requirement. Second important molecule that has come into perspective, and most of our type 1 diabetics also come and ask us about these molecules more and more, are the GLPs and the GIP molecules. So, how do they help us and why are they into too much of buzz? So, we know with the advent of obesity as a pandemic, GLPs and the GIPs, they are topping the charts as a first line molecule for our type 2 diabetic patients. But because of insulin resistance being a very important portion, the second important issues that we are facing with obesity now is the problem of hedonic eating. Hedonic eating is that we are having the society, we have had our food just now, but seeing our our friends or our colleagues having something which is carb rich and tempting, we still pound up more calories having those molecules. So we want some more molecules which can act at that center also. And nevertheless, controlling sugar is one portion, but over and above controlling sugar, we want to prevent the complications, as Pavitra madam rightly pointed out. We want to have cardiac benefit for our patient. We want to have renal benefits for our patients. So we require some cardio, renal, and metabolic benefits for our patients, which these molecules beautifully gave us for our type 2 diabetic patients. And when you talk about the GLPs, basically GLPs are the hormones which are naturally being secreted by the L cells, endocrine L cells of the small intestine, and they are in turn actually acting at the pancreas by glucose dependent action of increasing the insulin secretion and reducing the glucagon levels. It acts at the central nervous system at the hypothalamus by improving the satiety and reducing the requirement of the hedonic eating that nowadays we have. It improves the stomach emptying time is reduced, so it improves satiety to a great extent. And as I told you, at the level of liver, it also helps us with insulin sensitivity. And its better half, we can say, is the GIP. It's another molecule, another hormone, which is available as a dual combination now, which over and above these effects also acts at the level of adipocytes, at the level of fat cells. And we very well know that fat cell itself is a organ which is producing more amount of adipokines which are harming our body and preventing the problem of reducing the insulin dosage and improving the insulin sensitivity. So when we're giving a combination of these two molecules, it nips the evil in the bud, as we say. It targets insulin resistance and prevents the complications. So we have some clinical evidence for that also. We have some data that when it is being used in the adjust type 1 diabetic trial for semaglutide, which is a GLP, it brought down 10.7% weight reduction, and reciprocation into HbA1c reduction was seen. Liraglutide is once daily GLP, which also brought down around 5% of weight reduction. We talked about the twin incretin, that is the GLP with GIP, which is by the name of tirzepatide. For 12 months, the data was there where it brought down more weight reduction than the GLP because of its additional benefit, as I told you, and superior HbA1c reduction. So we have got these three molecules that helps us with improved insulin sensitivity, better glycemic control, less weight gain, and actually weight reduction, I can tell you. And we have got some data which is promising. We require some more data. One of the data again came up with adjust type 1 diabetic study, which showed that time in range that we see in the CGM improved to a great extent with our type 1 diabetic patients, and the insulin requirement reduced by 30% in our patients. Also, semaglutide helps with glycemic control. It is a very cardio, reno, metabolic protective molecule, and tirzepatide is the similar effect with additional benefits on the adipocytes. So we are preferring them more than the alone GLPs for the weight benefit for our patients. But because it is a newer molecule, semaglutide is more time tested than this tirzepatide molecule. Now, the third molecule that we can use as an insulin sensitizer and weight reduction propensation for our type 1 diabetics are the SGLT2 inhibitors. So what's the story of the SGLT2 inhibitors? Who are they? So basically, the SGLT2 inhibitors are the molecules which actually inhibit the SGLT2 present in the proximal tubules of the kidneys, and from where the maximum glucose reabsorption is done to the kidneys. So by preventing it, it causes glycosuria. So most of the glucose is excreted through the urine, and in that you have calorie reduction, indirectly causing weight reduction in our type 1 diabetic patients. So again, there are some things that have to be seen with SGLT2. They come third in line, as I told you, is because the weight reduction is modest, but the blood pressure reduction is better. It has got more renal safety data, more renal benefit data, more data with heart failure. So any type 1 diabetic who has got renal concerns, who has got heart failure concerns, in them as a weight benefit also we can use this molecule. Again, there are some things that we'll be talking about. It is not always a fairy tale with choosing the molecules in type 1 diabetics. What are the patient selection criterias where we would, as clinicians, be using these molecules for our type 1 diabetics? So a type 1 diabetic, the general consensus from most of the bodies is taking the BMI cutoff of more than 27 and having associated comorbidities, like a patient of type 1 diabetes having hypertension, patient having obstructive sleep apnea, patient having family history of heart failure, patient having family history of coronary artery events, patient having it himself has had a coronary event. So even at that BMI, we want this patient to be getting some benefits which insulin cannot offer alone. And even if the BMI is more than 30, still the patient can be taking it. But there is some issue with this cutoff for me in my mind, and I would request the others also to pound in with their thoughts, is that we Indians are basically thrifty, having thrifty phenotype. That is, we are thin outside and fat inside. So only BMI using as a cutoff is not going to be helpful. We have some anthropometric parameters where we see the waist by height ratio. If the waist by height ratio is more than 0.5, and even if the BMI is 25, still this can be helpful for reducing the visceral fat in our patients. So it is again an individualistic thing. The BMI cutoff always does not count for all patients. Typically, also we would not be using in type 1 diabetic patients who have gained weight on insulin to be getting this for weight reduction. No, 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 not at all, because we do not have much data on that in pregnancy, whether it is even type 2 diabetics. Yes, the best molecule would be GLP with a GIP, as for the weight reduction propensation. But you always have to be careful because we'll have to monitor more sugars with respect to these, because it has got a good glycemic control benefit also, not only the weight reduction portion. Talking about the second molecule, the SGLT2 inhibitors, the SGLT2 inhibitors are good, but they have got great risk of euglycemic diabetic ketoacidosis. So I think we very well know about diabetic ketoacidosis, but there are few patients who, because of the glycosuria, can develop ketogenesis and at normal sugar levels where their RBS is not more than 250 and the anandamide increases. So there is a very important risk for the same. So if suppose we are initiating our patients on these molecules, or as a type 1 diabetic, a child uses these molecules, it is very, very adolescent, not a child, adolescent or a adult type 1 diabetic having insulin resistance would be using these molecules. It is very, very important that it causes satiety. So the amount of food intake drastically goes down. So the prandial insulins are something, the bolus pricks are something that have to be sought for, and they should be reduced. And suddenly reducing your long acting insulins would not be a great choice, but bolus pricks should be the first which should be reduced. And the best thing, whenever a patient is put on a newer molecule along with insulin, the continuous glucose monitoring is definitely going to be important. There are some safety concerns that we should be talking when we are talking about these molecules. The most common side effects of GLP and GIP, as we talked, that it is going to cause a delayed gastric emptying. It is going to reduce your satiety. It is going to improve your satiety. It is going to reduce the gut movement. So there is more chance of GI side effects in the form of nausea, vomiting, that we see most with the GLPs. And when you're using a GLP GIP, it most commonly causes diarrhea-like side effects. So these things can be, monitored well, whether it is a type 2 or a type 1, but with slow titrations, with proper food adjustments, it can be very well, managed and can be prevented. But let's come with the other, molecule in the basket, the SGLT2 inhibitors. The SGLT2 inhibitors, as I told you, they are having more propensity to cause this euglycemic decay. And that is very difficult to treat because the sugar levels are less. The patient is more dehydrated. The patient loses a lot of water. So that is something which have to be taken into account. So the patient is more ketogenetic proof when the patient is having SGLT2. This have to be taken into very much account. And sometimes, because if there is a lot of glycosuria, a lot of sugar is being excreted from your kidneys, then the patient can also land up into dehydration. The kidney can have less perfusion of blood and can land up into AKI, that is acute kidney injury. So that is why these things have to be taken into account when you're using these molecules. Some very rare safety concerns would be the pancreatitis, which we have not seen for a long duration. We have been using in our clinics, and also we have our colleagues using it where we have not seen this effect. But if a type 1 diabetic has had an episode of pancreatitis, then this is not the right choice of using a GLP and a GIP. Gallbladder stones or cholecystitis, for that matter, is the most important concern where we would not be using it. But it is again a very rare thing. And patients having medullary thyroid carcinoma, MEN syndrome, these are some typical syndromes that have MTC, the medullary thyroid carcinoma, which can be propitiated or increased. But we have got rat models where we have seen this, but we do not initiate this molecule in these kind of patient population. But what can we do? What can we do if we want to initiate our patients on GLPs? Then we have some basic things that we can take into account. The bolus pricks, as I told you, you have to be very calculative for the amount of food that the adult or the adolescent is able to take. And along with that, the CGM monitoring helps us with the pre-meal calculations. And yes, the bolus pricks can be very well adjusted. And as you can see, the amount of basal in the beginning, we reduce around 10% in the first week. Then as the effect propitiates, in the second week, we try to reduce it by 20%. And also, a patient, higher the patient is insulin resistant, more will be the reduction required as the patient loses weight. And it is again the titration, which is very important, and proper careful monitoring, which we educate our patients when we are initiating them on such a molecule. Second would be very important about the sick day rules that we need to initiate. If a child, as I told you, if I'm extremely sorry, if an adolescent or an adult of type 1 diabetic is on GLP and suffering from a lot of vomitings and diarrheas, so these patients should be educated to stop the GLPs and meet us, and then we try to understand the cause of this vomiting or diarrhea, whether it was just drug induced or it was some kind of infection. But the sick day rules apply to that, as we very well know. With respect to the patients on the SGLT2 inhibitors, it is very important that we monitor their ketones. Whenever they look dehydrated, they have sugar spikes. But along with that, we, in spite of, as I told you, it's euglycemic diabetic ketoacidosis, where the glucose are not spiking to that extent. But a patient who is looking sicker, and typically who are on SGLT2, the most common problems are the genitourinary infections, because it is going to cause glycosuria. So it is going to cause balanitis, it is going to cause pyelonephritis, it will cause vulvovaginitis. So fungal infections in the urinal part or the genitourinary infections are very common. So if such infections are there, the patient is more prone to develop euglycemic decay. And proper monitoring of ketones, even on random weekly basis with the strip, the blood ketones can be seen, and doctors should be taken into account for the management, where hydration is very important along with the insulin requirement. I would just be finishing my presentation with one of the cases where typically we used the GLP molecule. So she's Ria, 18 years of age. She has been diagnosed with diabetes since 7 years. She was maintaining well on her total daily dose requirement of 35 units, was exercising well. But I think Madam highlighted an important fact that when there are competitive exams, or a girl is on the 12th standard preparing for her getting inside MBBS and preparing, where their long hours of sitting and the eating increases. So in 1 year's time, this poor child stopped all kind of activities, and her cycles, which were regular, the menstruations, which were regular, started becoming irregular, and her weight gain propitiated to a great extent of around 20 kg in 1 year, and her insulin requirements started increasing to around 60 units in 1 year's time. And she started showing signs of insulin resistance, which are acanthosis nigricans. She started developing central obesity. She started developing PCOS in her sonographic findings, in her blood parameters that we discussed. So such patients with typically the BMI reached to 30, they are requiring our help. So she is a typical case of type 1 diabetic patient developing obesity. We started her on semaglutide. The insulin dose requirement slowly reduced, and the hunger pangs that she was getting further because of the sugar cravings that she was getting because of insulin resistance reduced. She became more active. We educated her on the lifestyle changes that she requires to make. So my carry home messages for all of us would be that we have got some help for our type 1 diabetics, but we would definitely want all our type 1 diabetics to have a careful monitoring of their food habits right in the beginning, where we can prevent this pandemic of obesity in type 1 diabetic also. So typically the ADA 2026 is also propitiating the use of GLP receptor analogs as the first line agent for type 1 diabetes with obesity. As I told you, we would reserve the SGLT2 inhibitors mostly for patients, type 1 diabetic adults having history of coronary events or having history of kidney diseases. And with proper ketone monitoring, we can have a good monitoring for them, and we can be using an SGLT2 along with the basal bolus insulin that we are using for our type 1 diabetics. So we still require more data to just start these molecules on a whole soul basis, and we would require more and more associations with all doctors to carry out some more case based discussions on such patients so that we can learn more. Thank you. I rest my case. Thank you for your patient listening, and sorry for the technical clinch.
Thank you, Dr. Kansha, for so nicely summarizing about the various drugs used in type 1 diabetes. It's always a point of confusion. So if I'm a person with type 1 diabetes, when should I seek for obesity consultation? Or when should I start worrying about my weight? When would you say, if you could give some practical examples for our audience?
Madam would take it, or I should take it?
Anything. You want me to answer?
Anyone if you
Yeah.
want.
That's
So
okay.
I would request everybody, like the diabetic educator and the endocrinologist, to start plotting their weight and height and start calculating their BMIs. This is where we are going wrong. We just see their injection sites, we see the lipohypertrophies, the blood glucose logs, but we're not giving importance to the weight and height. So we do have growth charts. Why don't we start plotting on them, calculate BMI, and see where do they stand on the BMI? Early picking up of obesity or overweight itself will give us a clue where we have to put them on lifestyle changes than considering some medications for that.
Any other clinical signs that they can look for, Dr.
Yes, so
Kansha,
they
if you
can,
can?
so they can. I think Madam beautifully pointed out. This is everybody should take it into account. So we request about the pediatricians also that they should start, plotting the graphs, and the parent should be made aware when their percentile is going above 75. They should be alarmed about that. Secondly, if a type 1 diabetic, starts developing central obesity, this is something they should be aware about. Secondly, if they start seeing signs of insulin resistance, like they start getting blackening of skin around their neck, so many of them they start rubbing their neck thinking it is just the dirt which has accumulated, but the parents can also see the overall skin tags, which are, see, the small granular portions that you can see, the velvety portions, thick velvety portions at the neck. You can see the armpits which start becoming blacker. Also, as I told you about RIA, if a type 1 diabetic is menstruating well, a female, and she starts developing irregular cycles, it could be either two things. Either it could be premature ovarian insufficiency, or it could be development of PCOS if she's gaining weight. So most commonly, if you're gaining weight, it is mostly PCOS, and this can be very well addressed if the weight is not pounding to that extent. These are two things, and typically that sugar cravings, which were not there earlier, and you start getting those sugar cravings again and again, they also give a very good highlight of insulin resistance.
There's one audience question which I'll take. So, if people with type 1 diabetes have not yet started exercising, how can we manage duration and type of exercise?
Madam, you
So,
can take it first. Yeah.
yeah. So, if you've not yet started exercising, please do. I think this whole session is about that you need to have lifestyle modification in place. So, one of the rules that we usually tell all our patients is that you start exercising at a fixed time for a fixed duration every day and try to do a similar kind of exercise every day so that you can predict what kind of a response it will have on your blood glucose. Typically, start with half an hour and then gradually increase the time. Now, if you're aiming for weight loss, then you need to reduce the insulin dose rather than have an extra snack. But if you're not aiming for weight loss, you just want fitness, then you can add a 15 grams carbohydrate snack along with some protein before you start the exercise for half an hour to 45 minutes of moderate intensity exercise. So let's say a brisk walk or cycling, or maybe if you're going to a dance class where you're not continuously dancing. So something like that. Now, if you're going to exercise in the mornings, you may not require an extra snack, but you may require some extra insulin. If you're going to exercise in the evening, you definitely need to reduce your insulin doses. If you do regular exercise, we have seen that there is some reduction in the basal insulin that needs to be done over a period of time to prevent delayed hypoglycemia. So one thing that the audience needs to remember, that if you want to exercise for weight loss, you need to adjust the insulin dose. Otherwise, you're just going to eat all the calories that you're burning. Right.
So just to add to this, there
Yes.
is a difference between an aerobic and an anaerobic. So don't go for a vigorous activity which will just drop your sugars. और क्या होता है बाद में the sugar starts increasing. So we will have to look into those, as Anushri rightly mentioned, brisk walking, normal walking, cycling. You might not have to titrate the insulin so much as you go for an aerobic exercises, vigorous activities. So as a routine, you can do walking, cycling. The best is yoga as well at home if you're scared of going out and doing physical activities. That also should suffice.
I would also like to add something. So there are three things that we, with the first time a patient is wanting to go for exercises, the parents should be educated about three vital rules. Firstly would be, if the sugars pre-exercise are less than 90, it is it is idealistic to give them a 15-gram carb with protein, as Anushri pointed out. If the sugars are between 90 to 150, it is mostly a very good thing. As madam said, aerobic workouts, you won't require much of a help. But after 30 minutes of aerobic activity, just see the sugars once. If the sugars are again remaining stable below 200, it should be fine. But if the sugars are above 250, do not just pound in working out to a great extent, because we are more prone to ketosis. Second, very important that we have seen with our athletic type 1 diabetes is that it is very important that the exercise should become very slowly. So it is like the stretchings should begin slowly. The activities should keep on increasing. For suppose if you are doing some strength training, so if you can just do with the weight liftings with first 2.5 kg, then you increase slowly with 5 kg, then you increase it with 8 kg, then you slowly downscale it also. Do not stop your workout at 5 kg of strength training and just stop it. Then go again to 2.5 kg, again to stretching, and then finish off your exercise. When you're doing it in this way, there is no further spike in your glucose from the liver, and there will be a clear graph So the patients would not land up into hypers and hyper. There will be no more of a glycemic fluctuation. The things will be better.
Okay. So we need to talk a little bit in Hindi also. There's one question that I wanted to ask both of y'all, which is a very common myth, is what is the effect of thyroid on weight? Because a lot of our type 1 patients are hypothyroid, and I would really love for y'all to clarify about that. थायराइड इफ यू कैन टॉक अ लिटिल इन हिंदी, थायराइड और वेट का क्या
Sure. ठीक है.
रिलेशनशिप है?
Okay.
If Akansha can
I
talk
think,
about this.
yes, ma'am. मैम मैं ले लेती हूँ. That's okay. So basically हमारे पास बहुत सारे पेशेंट्स आते हैं, ये बोलते हैं कि भाई मेरा वेट बढ़ गया क्योंकि मेरे को थायराइड है. सी, जब किसी का थायराइड कम काम, सो देर आर दो तकलीफें हो सकती हैं. या तो आपका थायराइड बहुत कम काम कर रहा है, या तो आपका थायराइड ज्यादा काम कर रहा है. ये दो प्रकार की बीमारियां देखी जाती हैं टाइप 1 को. ये हो सकती है बिकॉज ये ऑटो इम्यून प्रॉब्लम है. अगर आपका थायराइड बहुत ज्यादा काम कर रहा है, आपका हार्मोन बहुत ज्यादा बना रहा है, तो आपका उसकी वजह से वेट कम होते जाएगा. सो अगर आपका थायराइड नॉर्मल कर देते हैं हम दवाई देके, तो आपका फिर से वेट न्यूट्रलाइज होके नॉर्मल होना स्टार्ट हो जाएगा. अब इससे ऑपोजिट जो बहुत कॉमन प्रॉब्लम जो अनुश्री बता रहे हैं कि अगर आपका थायराइड काम ही कम कर रहा है तो हम बाहर से आपको सप्लीमेंट दे रहे हैं. तो नॉर्मली आपका थायराइड ग्लैंड करता क्या है, वो दो केमिकल बनाता है, दो हॉर्मोन्स बनाता है, T3 T4 नाम के. वो दोनों केमिकल्स का काम होता है कि आपकी पचन क्रिया को नॉर्मल रखना, आपके मेटाबॉलिज्म को सही रखना, आपके शरीर में नमक और पानी का बैलेंस सही रखना, आपकी इंसुलिन सेंसिटिविटी को अच्छा रखना, आपकी स्किन को अच्छा रखना. अब अगर किसी की बॉडी के अंदर थायराइड हार्मोन कम बनता है तो आपकी पचन क्रिया धीमी पड़ जाती है. तो आप इतनी अच्छी तरह कैलोरीज बर्न नहीं करते जितना एक पेशेंट यू थायराइड है जिसकी थायराइड हार्मोन नॉर्मल काम करती है. बट इसका मतलब ये नहीं है कि आपको थायराइड की वजह से ही सारा वेट बढ़े जा रहा है. मैक्सिमम हमने देखा है कि 3 to 5 kg, मैक्स टू मैक्स बोल रही हूँ मैं, मोस्टली 2.5 से 3 kg का शरीर में सूजन आ जाता है बिकॉज आपके शरीर में नमक का रिटेंशन बहुत हो जाता है जब आपको हाइपोथायराइडिज्म होता है जो अनकंट्रोल होता है. अगर आप हाइपोथायराइडिज्म को कंट्रोल कर लेते हैं तो आपकी, हम बाहर से दवाई देके आपकी थायराइड को नॉर्मल काम करवा रहे हैं, तो आपकी पचन क्रिया हम ऑलमोस्ट नेचुरली कंट्रोल करने की कोशिश भी कर लेते हैं. अब तो हमारे पास में T3 हार्मोन भी अवेलेबल है जो एक्टिव हार्मोन होता है. जब हम वो हार्मोन भी अब ऐड कर रहे हैं जिनका थायराइड कंट्रोल होते हुए भी उनको ये बहुत ज्यादा वेट का प्रॉब्लम लग रहा है, वो सब एक्सरसाइज भी कर रहे हैं फिर भी बहुत सूजन लग रही है, तो उस टाइम पे ये दवाई भी बहुत मदद करती है. बट द बॉटम लाइन इज, ये सबसे इंपॉर्टेंट चीज है कि आपके जो फैट के सेल्स होते हैं वो बेसिकली खुद एक ऑर्गन है जो पानी को सोखते हैं, आप ऐसा समझिए. तो आपकी बॉडी के अंदर लिम्फेटिक्स जो क्लियर करते हैं सारे फ्लूइड्स को, वो काम नहीं कर पाते, जिसकी वजह से आपकी बॉडी के अंदर वाटर रिटेंशन रहता है फैट इटसेल्फ की वजह से, खाली थायराइड की वजह से नहीं. तो अगर आप फैट रिडक्शन करेंगे जो खाली थायराइड हार्मोन से नहीं होने वाला है, जो इंसुलिन रेजिस्टेंस की वजह से मोस्टली डेवलप होता है 99% केसेस में, तो आपको वेट रिडक्शन मिल सकता है. आपका थायराइड नॉर्मल रहते हुए भी आपका वेट ज्यादा हो सकता है बिकॉज आप इंसुलिन रेजिस्टेंट हो. तो आपने वर्कआउट, आपका फूड इनटेक, वो सबको भी बैलेंस करना बहुत जरूरी है, भले आपका थायराइड नॉर्मल हो तो भी. तो बिल्कुल अफेक्ट होता है वेट के ऊपर, बट हम जिस मिथ्या में रहते हैं कि भाई उससे बहुत फर्क पड़ जाता है, मेरा थायराइड नॉर्मल होते हुए भी मेरा वेट बहुत ज्यादा है, तो हमें और कोई कारण देखने की जरूरत है.
So just to add on, there is subclinical hypothyroidism where the TSH is between 5 to 10. That is when we are not going to treat them. We're going to tell
Yes.
them to reduce the weight. And if it is the weight gain is because of hypothyroid, TSH would not be in tens or 20s. It would be much higher. So please see to it that if the TSH is less, it's because of the overweight and obesity that the TSH has gone high. So we wouldn't treat subclinical hypothyroidism.
आई थिंक मैडम ने बहुत अच्छा पॉइंट हमारे लिए रख दिया है कि अगर टीएसएच 10 से ज्यादा है तो मोस्टली आपकी थायराइड ग्रंथि कम काम कर रही है जिसकी वजह से आपका टीएसएच ज्यादा हुआ है. लेकिन अगर आपकी बॉडी के अंदर ओबेसिटी का पोर्शन है जिसकी वजह से बॉडी में कुछ मैकेनिज्म्स होते हैं जिसकी वजह से टीएसएच ज्यादा दिखता है, जिसको हम सब क्लिनिकल हाइपोथायराइडिज्म बोलते हैं. तो जब तक आपका टीएसएच 5 से 10 के बीच में है और आपका हम एंटी टीपीओ एंटीबॉडी करवाएं और वो नेगेटिव है, तो वेट जैसे ही रिड्यूस होगा तो टीएसएच अपने आप नॉर्मल हो जाएगा. उसमें दवाइयों की जरूरत नहीं है थायराइड को नॉर्मलाइज करने के लिए. थैंक यू मैम फॉर टेकिंग दैट पॉइंट अप.
Okay. So I think we can just take a few take-home messages or give a few take-home messages, and then it's already 7:30, so we can conclude our session for today.
Yeah. So,
Dr. Pavitra, would give a
yeah.
few messages, and then
So,
Dr.
I would request, even if the pediatrician or the diabetic educators are busy plotting the weight and height, it's very easy to calculate. You have many apps on the internet. You can just put the weight and height and see if the child is going into towards the overweight and obesity. To all the parents, please check the weight and height at least 3 monthly, 6 monthly, so that we know where the child is going. The second thing is, do not be scared when the CGMS shows a narrow which is going down, and that is when you start junking, you start eating sugars. So wait, check with the glucometer, because always CGMS can have a variation of 10 to 15 up to 20 is also acceptable. So check with the glucometer. If the child is symptomatic, if the low sugars, only then act. You don't have to act just because CGMS is showing a down arrow. The third thing is, I know they get carried away with peer groups, start eating junks, going out. So try to avoid that. Just because you have insulin with you and you can control sugar, that doesn't mean that they can eat everything. So you can tell them, okay, once in a month, once in 2 months, that is when they can go out and eat. Physical activity is a must. Screen time is also one more thing which I forgot to mention. So screen time to be cut down, eating in front of gadgets, which will again increase the cortisol and increase the hunger. So please see to it that the children are not glued to the screen, and whenever they eat, everything is off and they concentrate on the food. Half an hour of walking, little walking, cycling, yoga would definitely help control the sugars. And as Anushri said, the amount of insulin requirement will also come down. So I would request all of you to get annually checked for the comorbidities as well, along with the HbA1c, which you do every 3 monthly.
Dr. Akansha, any take-home messages?
I think Pavitra madam has beautifully point everything. I have nothing more to say, but I just, this is personally what I tell my type 1s. I would just like to share one or two things. I try that they get inculcated into sports activity to a great extent right in the beginning. That creates a lot of awareness. We do not have to tell them, please beta ये मत खाओ, ये खाओ. वो अपने आप इतने अवेयर हो जाते हैं. हमारे पास कुछ टाइप 1 हैं जो डांसर्स हैं बहुत अच्छे, तो वो इतने लेवल के अच्छे डांसर्स है कि उनको हमें बताना नहीं पड़ता कि आप ये मत खाओ, ये खाओ. और व्हेन वी आर डूइंग सम ग्रुप मीटिंग्स फॉर अवर टाइप 1 डायबिटिक्स, तो वो उनके लिए एक रोल मॉडल हो जाते हैं. तो जब वो बताते हैं कि वो क्या करते हैं, तो आप ऐसे क्लिनिक्स में जहाँ पे ग्रुप्स बन जाते हैं, आप ऐसे रोल मॉडल से भी जब अपने बच्चों को मिलवाएंगे, तो उनको एक मार्गदर्शन मिल जाता है कि हमें भी ऐसा बनना है. तो ऑटोमेटिकली लाइफस्टाइल, ये जो हमें बताना पड़ रहा है, ये मत करो, ये करो, और वेरी इंपॉर्टेंट वुड बी पूरी फैमिली को ये करना है जो टाइप 1 को करना है. इट इज नॉट फॉर टाइप 1 अलोन. हम सबको बोलते हैं कि प्लीज ये कार्ब सेंट्रिक जो फूड इनटेक आप कर रहे हैं, आप भी मत खाइए, आपकी हेल्थ भी कुछ. सो व्हाट वी स्टार्टेड डूइंग इज वी डू बॉडी कॉम्पोजिशन एनालिसिस. तो हम बच्चों का भी करते हैं, हम माँ बाप का भी करते हैं, और हम बता देते हैं कि भाई क्या क्या प्रॉब्लम्स हैं. सो हमको लगता है आपको भी एक एम मिला हुआ है, आपको भी करना चाहिए, आपकी भी हेल्थ अच्छी रहेगी. तो साथ में फैमिली, when the family is involved, things become very helpful. Yeah, that is what I would like to. This is something practical that we do here. Thank you.
Thank you to both our speakers. तो हमने कुछ बहुत इंपॉर्टेंट चीजें आज सीखी है. पहली चीज तो हमने ये सीखी है कि मोटापा टाइप 1 डायबिटीज में भी आ सकता है. आपको टाइप 1 डायबिटीज है, टाइप 2 नहीं है, तो इसका ये मतलब नहीं है कि मोटापे के जो इश्यूज है या जो प्रॉब्लम्स है वो आपको नहीं होंगे. दूसरा बहुत जरूरी पॉइंट हमने सीखा है कि एक्सरसाइज बहुत इंपॉर्टेंट है. फिजिकल एक्टिविटी किसी भी तरह का आपकी लाइफ में आपको इंक्लूड करना है. अगर उससे बार बार लो शुगर हो रही है तो आपको डॉक्टर को मिल के अपना डोज एडजस्ट करना जरूरी है. तीसरा है कि खाना पीना या लाइफस्टाइल मॉडिफिकेशन जो हम बोलते हैं वो टाइप 1 डायबिटीज में ही उतना ही जरूरी है. आपने खाना कार्बोहाइड्रेट काउंटिंग करके इंसुलिन ले लिया, शुगर आपका ठीक है, बस उतना ही अचीव करना इम्पोर्टेंट नहीं है. आपको खाने का बैलेंस रखना है और उसके लिए जो भी आपको हेल्प लेनी है वो आपको देनी है. एंड थर्ड वेरी इंपॉर्टेंट इज दैट प्लीज रेगुलरली विजिट द डॉक्टर, गेट योर चेकअप्स डन. You are young, but that does not mean that you have a golden thread. You are prone to many complications. And there are a lot of new developments which keep happening in the medical field, which you're going to refrain or आप उसका फायदा नहीं ले पाएंगे because आप regularly डॉक्टर को विजिट नहीं कर सकते. मोटापे के लिए अभी हमारे पास ड्रग्स भी है जो हम टाइप 1 डायबिटीज में अंडर गाइडेंस सेफली ले सकते हैं. और उसके अलावा जो भी मेडिकल केयर आपको लगती है फॉर ओबेसिटी वो आप डॉक्टर से जाके ले सकते हैं. So thank you everyone for this session on Empower T1D and hope to see you in the next month again. Thank you. Thank you, Dr. Akansha. Thank you, Dr. Pavitra.
Thank you. Thank you, Anisha and Pavitra ma'am. Team Empower Type 1 Diabetes for inviting me today.